Assalamu alaikum wa rahmatullahi wa barakatuh. Hello everyone and welcome to one of our quick session in which we summarize together one of the TOG articles, and today we are going to talk about the investigation and management of post-coital bleeding. As you can see, it's one of the recent TOG articles and it's crucial for your exam because this is one of the modules of the gynecological modules and one of the most important topics in the gynecological modules. Postcoital bleeding is still a controversial topic, not because it's difficult or something, but because there is inconsistency in the investigation and the line of management. And this is why our respectful doctors here wrote this articles to highlight how we should be oriented or how should we organize our thinking about management and treatment of postcoital bleeding. First of all, we have to know what is cold-pointed bleeding. As usual, we are going to focus on the points that may appear conflicting to you during your exam question. I know that most of you know how to investigate, how to treat, how to deal with a patient with postcoital bleeding, but the problem is the priority and how to think about ordering the investigation, uh, which is first, which is more important, and so on. First of all, the postcoital bleeding is a common gynecological bleeding, of course, but it may be, and most of the time, it's because of benign cause, and sometimes it's because of invasive cervical cancer. The problem is postcoital bleeding is commoner in women with invasive cervical cancer, while most women with postcoital bleeding will not have an underlying malignancy. This may appear conflicting, but if you just focus for a minute with me, you are going to figure it out. When we count women with postcoital bleeding, we are going to find that many of them is not going to have malignancy. Okay? However, however, women with underlying malignancies are having more common risk or commoner risk to have postcoital bleeding. I cannot make it more simple than this or simpler than this. Anyway, to understand postcoital bleeding, you have to make sure of very important thing. Are we talking about postcoital bleeding alone, or there is intermingling symptom with it? This is very important during your investigation and management. If we are talking about postcoital bleeding alone, this may be caused by cervical lesion, vaginal lesion, vulval lesion. Sometime, sometime it will be because of endometrial pathology also, but it's not that common. We call this intermenstrual bleeding. When the lesion is in the endometrium, it tends to appear mainly in between the periods, not after the sexual intercourse. Okay, so when those causes of bleeding coexist, they will have different management of having a postcoital bleeding alone. This is why the history is very important in your management. You have to take care in the question whether there is a history of intermenstrual bleeding or not. Is it heavy or just spotting? If there investigations have been done to exclude endometrial hyperplasia or not? Those are very important questions. So again, to be organized in our thinking, the causes of postcoital bleeding. We have benign conditions, which are commoner. We have infection. We have vulval benign lesions. We have other causes like the trauma or bleeding disorders or foreign bodies or sexual abuse. Maybe it's pregnancy related. This is very common in pregnancy physiologically because of the high level of estrogen in the blood of the pregnant woman. or because of the female genital mutilation, a recent act of FGM, or a complicated lesion from a previous FGM that bleeds after every sexual intercourse. Okay, so the history is crucial. The history is crucial. Why? Because I need to know the patient age, because this would make her at risk of cervical malignancy if it is postmenopausal, of course. Any postmenopausal bleeding should be investigated urgently and should be referred within 2 weeks. Okay? The duration, the frequency, the amount of bleeding, all of them are keys for me as a doctor, as a gynecologist, to know what is the most common cause of this bleeding. Is this woman is having a natural menstrual history? Is her period irregular? Because if she's having irregular periods, how can I know that this is a postcoital bleeding, not just irregular menses or an intermenstrual bleeding? This is very important also. Does she have another symptoms like vaginal discharge? This can help me diagnosing infections. If there is pelvic pain, maybe this is also PID or endometritis caused by ICD, or let's say endometriosis. Is there dyspareunia? Maybe it will also help me to think about endometriosis. If there is contraception history, and this is very important in your exam, many cases and many recalls are talking about postcoital bleeding in a woman who is using a contraceptive method. Mainly, this woman is going to be on COCs, anything that contain estrogen. And because of this high level of estrogen, her cervix is not dealing normally with it, and it will develop changes in the cells of the cervix called cervical ectropion. Cervical ectropion, and we are going to talk about it in a little bit, is a benign lesion, nothing to worry about. However, I should make sure that the COC is the reason why this woman is having the postcoital bleeding. And we are going to talk about what to do in such cases. Not to forget that also other hormonal therapies can do it, like tamoxifen. Patients who are having breast cancer and now they are using the hormonal therapy to minimize the invasions of cancer cells through their body, or let's say in a simple words, control the cancer cell transformation in their body. The tamoxifen will cause them some side effects, just like spotting, uh, postcoital bleeding, intermenstrual bleeding, if they are, of course, having menses, and of course, something like hot flushes and so on. So keep it in your mind when you have a patient with tamoxifen, this patient could have only a cervical lesion caused by the tamoxifen, or maybe she is having an endometrial lesion caused also by the tamoxifen. So this should be excluded. This woman is at high risk of endometrial cancer because tamoxifen is taken at least for 2 years. Sometimes we can use it for 5 years, sometimes for 10 years. So this is a prolonged period on something act like estrogen in our body. So it has an adverse effect on the endometrium. That's why I'm telling you the history is crucial. Again, the cervical screening. What is the HPV status of this patient? Is she having her screening routinely? Is the last smear okay? Is she due to her next cervical screening? Okay. What about a previous colposcopy? Did she have a previous colposcopy? What was the results? The sexual history, the post-medical history, and so on. And of course, the bleeding disorders and any use of anticoagulants. Okay, now let's talk a little bit about examination and how it can help us with the diagnosis of postcoital bleeding causes. I choose to read from the TOG article itself today because you are going to have the summary in our TOG channel in the Telegram, so please go check it. But I need you to see how the TOG article is classified, and he did a great job actually in informing us very systematically about everything. Now the examination, they talked about that the casco or the casco speculum is very important. Of course, you should inspect the vaginal walls. You should expect any lacerations, any ulcerated lesions that could be vaginal cancer. Okay, yes, it's not common, but it's still a cause. So I shouldn't exclude it until I see, look and see. The casco speculum is our friend for vaginal and cervical examination. And when you are going to do it, you are going to see any apparent lesion in the vagina or the cervix. Of course, you are going to note any abnormal vaginal discharge or if there is a foreign body. Um, don't take it easy. In the real life, you are going to find foreign bodies. Sometimes foreign bodies are out of, out of our scope, especially in the adults. But trust me, you can find it. You still can find some hair from shaving or whatever, or from the male partner. This foreign body can cause some reactions. Sometimes the sex toys and something like this will be there. Sometimes the woman is doing like regular douching for the vagina, and a part of the douching is messed up inside. It can happen, so please keep it in your mind. Okay, of course, the cervical examination will reveal any ectopy or polyp or any abnormal appearance that would lead you to offer this patient colposcopy. Look, guys, any abnormality in the cervix that you suspect to have abnormal appearance of the cervix or cancerous appearance or metastatic appearance, name it as you want, but the colposcopy will reveal any deep invasion or any deep pathology that is not obvious to your eyes, especially if it's intracervical or in I'm not saying it's not superficial lesion. Okay, so we have sometimes like keys. We have some keys during cervical examination. When we found it, we're going to order the colposcopy. The main reason why we should order colposcopy is HPV positive test. A recent screening that reveals HPV positive test. Any HPV positive test should be referred for colposcopy. Okay, now we have done with our examination. What should we do? Our examination revealed something suspicious, or it reveals a picture of infection, or maybe it's normal, but there is a persistent postcoital bleeding in the history, or coexistent intermenstrual bleeding. This is very important in your exam. During answering the cases, please pay attention with me in this point. I'm going to use my marker. Okay, when you have a case in your exam with normal cervix and there is a coexistent intermenstrual bleeding, they are going to tell you that not only this woman is having postcoital bleeding, but also she's having intermenstrual bleeding. That means that you have to keep in your mind that this may be endometrial pathology, not only cervical pathology. That's why we should consider TVS initially, of course, and plus or minus, plus or minus Pipel biopsy plus or minus hysteroscopy. When should I do a pipal biopsy? When the TVS revealed a polyp, submucal polyp. So it will be very easy if I just go and with my speculum and take this polyp out. Pipal biopsy is just using the pipal forceps and doing exclusion uh, of this polyp and send it for pathology. Okay, what if I'm not sure of what I'm seeing, or the or this patient is high risk, or I want to see more. It's not just one polyp. There are several polyps. There is uh, irregularity in the endometrial lining, something like this. I would do outpatient hysteroscopy. Okay, and this will be in consistency with the guideline of heavy menstrual bleeding or intermenstrual bleeding. Okay, okay. Now, what if I'm having a clinically abnormal cervix? Colposcopy, of course. What if the screening test is overdue? Ma'am, hi, how are you? Okay, I can see that your cervical screening test is in 1 month, right? She will say, yeah. Okay. What about we will do it now because you are having postcoital bleeding now. So we are going to do the screening test, okay? And if it's abnormal test, of course, this means colposcopy. Okay, so we have two indications for colposcopy, either clinically abnormal cervix or cervical screening test that is very near. Okay, so I'm going to do it. And according to the results of the cytology is positive or the HPV is positive, I will do a colposcopy. Of course, we depend mainly on the HPV results. Okay, and you can refer to the flow chart of the cervical screening to help you with this. Last but not least, the microbiology swab. This patient is having history and examination suggestive of having cervicitis. So I'm going to take a microbiology swab. If positive, I will treat the infection and refer to the GUM clinic, of course, for contact tracing. Okay, this algorithm is really, really beautiful. There is some question, they call it HARK, HARK. Humiliation, afraid, rape, and kick, because those questions will reveal to us if this patient is having intimate partner violence. Okay, um, I'm going to talk about something about the hysteroscopy that they emphasized here in the TOG article. And I think it's really important to know. Hysteroscopy, guys, not only they exclude the endometrial pathology, but also they give us a detailed image of the endocervical canal. Okay, so they are really, really beneficial. The colposcopy, on the other side, gives us an idea about the endocervical lesion. Sometimes the lesion is having manifestations, but it's not apparent. Okay, maybe it's not apparent. And that's why they said here in the history and physical examination when the cervical screening test is overdue. That means I'm going to do it. And if it's abnormal, I'm going to do a colposcopy, even if the cervix is looking not really pathological, not really suspicious. Why? Because as you can see here, I think it's written here. Oh, okay. They are revising with you when to offer colposcopy, and so on. When you have abnormal cytology, low-grade dyskeriosis, okay. And they are also required colposcopy if they have two sequential inadequate tests. This is also a revision on the flowchart of cervical screening. However, look here, in the context of postcoital bleeding, women require a colposcopic assessment within 2 weeks if the appearance of the cervix is suspicious. So you don't need to have a diagnostic cervical lesion if it's only suspicious for you. Only suspicious for you. Another thing is gynecologists. Gynecologists may refer this woman on for symptomatic colposcopic examination outside the cervical screening program if cancer is suspected. That's what I was talking to you about. If I'm having a patient who is risky for cervical cancer, she's risky. She's having postcoital bleeding, but the cervix is not that really high index. What should I do? I should refer her to colposcopy. Okay? That's why I'm telling you, even if it's not really that suspicious, okay, but she's high risk, I should refer her for colposcopy. We mention it here again. Um, I think in the cervical cancer part. Okay. Anyway, as you can see, they are telling us each and every cause and what to do with it. Um, I know I read it somewhere. We will come to it. Okay. The colposcopy, as I told you, they reveal the endocervical lesions, which may be not apparent to you. Okay, I just need you to remember this. Okay, about the causes and how to manage them. First of all, they mentioned the cervical extropium because it's physiological finding because of high estrogen level in the blood. Maybe it's because of having the estrogen by any mean like COC or tamoxifen or monotherapy or whatever, or because she's pregnant. What should I do if I'm having a cervical ectropion case? Usually, you don't need to treat this case, okay? But if she needs treatment, if she asks for treatment, you are going to treat her. And this is a very tricky point in the question of the exam. I will just forward a case scenario, okay, about a woman who is having everything normal apart from cervical ectropion, and she's having postcoital bleeding, and she asked for treatment, okay, and this woman was on oral contraceptive pills. Usually, if this patient is not asking for treatment, the best management for her will be stopping the COC and turning or switching to another kind of contraception. But because she's asking for a treatment, the correct answer will be either the application of silver nitrate or cryotherapy or dietherapy. As you can see here, sorry, as you can see here, given this reassurance, because it's physiological nature of the condition, the patient may decide not to have any further treatment. If applicable, changing the combined oral contraceptives to the progesterone-only pill may resolve symptoms. Women with persistent or troublesome symptoms can be offered cryotherapy or diathermy to the cervix. That means that when the question is asking you about treatment, don't choose stopping COC. This is not a pharmacological or um, a line of treatment. Okay, this is line of management. Okay, this is a very tricky point, but it happens. It's a very famous record. Okay, but if they are asking about what is the best next step or what is the best line of management, it will be switching the COC. Okay, because maybe when she stopped the COC and switch it to another kind of contraception, the bleeding will stop. Okay, another thing about it is if this woman is having regular and negative cervical screening, her screening is clear, and you cannot see anything suspicious except of ectropion. Okay, this is a diagnosis of an ectropion. So cryocautery could not be done. You don't have to do it. You can just reassure her. But if you are planning to do a cryocautery, you are going to do it in the gynecologic clinic. And if you have any doubts, again, if you have any doubts, you should do a cervical biopsy. And the treatment should be delayed until the histology is known. So again, this is an indication for colposcopy and biopsy. That's why I'm telling you, whenever you have any suspicion, you should refer this woman for colposcopy and biopsy. Okay, about the cervical polyps, you know that they are very friable and they can easily bleed on contact, and that's why they tend to bleed during the sexual intercourse, and the bleeding will be obvious after the intercourse is done. The symptomatic polyps, when it have a coexistence with abnormal cervical cytology, they should be removed and sent for histological examination. Why? Because we need to exclude malignancy. Okay? And that's why most of the cervical polyps that you are going to find, they can be avulsed, as we said before, during the speculum examination. This is this is very easy, and they will be grabbed or grasped by the polyp forceps and sent for pathology. Okay. Again, they are telling you here that hemostasis can usually be achieved with silver nitrate after the removal of the polyp. Maybe you can use loop diathermy if you are doing a colposcopy and you find the polyp also. Anyway, this is very important. This figure here. Endometrial abnormalities have been reported in up to 55% of post-menopausal women with cervical polyps. This is very important in the exam. Not any woman we are talking about, post-menopausal women. When you are having postmenopausal women with cervical polyp, that means that 55% of them will have endometrial abnormalities. And that's why those women should be offered hysteroscopy and endometrial sampling. And again, this is apart from the GTG talking about endometrial cancer and endometrial hyperplasia. If you refer to the guideline of endometrial hyperplasia, you are going to find that whenever you find a cervical polyp and you do a hysteroscopy to exclude endometrial pathology, you should do hysteroscopy and endometrial sampling specifically for postmenopausal women. Another woman is very high risk for this lesion, you know. Which one? Yes, yes, excellent. As I'm sure that all of you figured out the woman on tamoxifen. Women on tamoxifen are very liable to have endometrial hyperplasia, and that's why when we have a woman with postcoital bleeding or irregular bleeding or irregular spotting or whatever kind of bleeding during having tamoxifen therapy, she should have hysteroscopy and biopsy or endometrial sampling. And of course, if you find a polyp, you are going to do a vulsion of this polyp and send it to pathology. The TOG article continued to talk about the cervicitis, endometritis, PID, and they, of course, remind us with the regimens for the PID. You are going to find it underneath, according to the PASH guidelines, of course. Cervical cancer, I know you are all aware of how to treat CIN, which kind of CIN need treatment, which kind of CIN needs follow up. Of course, we are talking about CIN1 would would need follow up, and CIN2 or 3 will need treatment with leads. Okay, so they are again reminding you with how to deal with CIN in different cases and how to recall each woman. I prefer not reading this from here. The algorithm for cervical screening is much, much better. Okay. Last but not least, the vulval and vaginal lesions. I need you to remember one thing. What is the most common cause of postmenopausal bleeding? Yes, it's vaginal or urogenital atrophy. The urogenital atrophy that results from the estrogen deficiency is the most common cause of postmenopausal bleeding in women. Okay? She is going to tell you that she's having vulvovaginal dryness or irritation or decreased lubrication or superficial dyspareunia or postcoital bleeding. Okay? But you need to what? To exclude any cause of endometrial bleeding. You need to exclude any cervical pathology. You need to make sure that this woman is not having a pre-malignant lesion. Okay? So again, I'm reminding you that history is very important. Calculating the risk factors is really important. And remembering the algorithm of postmenopausal bleeding, of course, is crucial. When you are going to have a TVS for this woman, specifically if she's having intermenstrual bleeding, not only postcoital bleeding, you are going to manage her according to the endometrial thickness. If you can remember this TOG, this is one of the most important TOGs, post-menopausal bleeding, or no, its name was detecting endometrial cancer. When the TVS show endometrial thickness more than 4 millimeters, this needs further investigation in means of hysteroscopy and biopsy. Okay, when it's less than 4 and this woman is low risk and the bleeding is not recurrent, I can reassure her. But if she's high risk and the lining is irregular, or there are polyps, or there any endometrial pathology, or of course it's more than 4 millimeter, I'm going to do a biopsy, and according to the biopsy, I'm going to do the further management. Okay, in this case, I will suppose that my patient here is only having dry vagina. Okay, the treatment will be very easy. It will include any vaginal moisturizers, lubricants, or topical estrogens. Those are the first line. Then, or she can use DHEA or osmipifene, which is a new drug for those cases, specifically for those who have low desire. Osmipifene is mentioned in HRT new guidelines, or laser in irresponsiveness of the vagina to the local estrogen, or the need for long-term usage of estrogen. Vulval dermatosis. You know that vulva sometimes can be sick. Vulva can have a pathology that leads to some bleeding during intercourse. So any kind of dermatosis, any contact dermatitis may cause the postcoital bleeding. anything that causes fissuring of the skin. Maybe some women have just shaved her labia or whatever, and when she had the intercourse, the friction caused some bleeding. Maybe it's that simple. Yeah, maybe it's that simple. So examination is very important to see if there is abrasions in the skin, fissuring in the skin, if there is lichenification, if there are signs of allergy, is there signs of skin integrity loss. Okay, if there are any pigmented lesions, eroded areas, ulcerated areas, all of those can help us with the diagnosis. Of course, the skin lichen sclerosis is one of the causes, and we fear from lichen sclerosis. Why? Because it has up to 6.7% risk of developing squamous cell carcinoma. And that's why we fear lichen sclerosis. But other than this, we can reassure the patient that she's having a benign condition and she just needs follow up. She can use moisturizers, she can stop using soaps, she can have emollients, topical steroids if she need it. She's having allergy or let's say contact dermatitis from something. Maybe it's from the underwear material or even from the latex of the condom. She can develop some allergy. Anything is possible. So keep everything in your mind. Anyway, your job is to exclude the severe cases or the malignant pathology or the disastrous causes. Okay. Then when we can exclude them, we can reassure the patient. Pigmentation is really, really important, and please don't underestimate any pigmentation in the vulva. Any pigmentation in the vulva can be vulval melanoma. Vulval melanoma is a cancerous lesion. Okay, so uh, when you have a postcoital bleeding and there is a vulval melanoma, I should inspect this closely and I should refer her to do further examination. Maybe she will need excisional biopsy also. Okay, I think we have reached the end of our discussion today, and I know it's a little bit long video, not a short one, but I think we have revised many things through our discussion. Thank you very much for being with me today. If you like this discussion, please share it with your friends, and please don't forget to link this talk with the detecting endometrial cancer TOG and the endometrial hyperplasia GTG. This is very important, and the cervical screening program flowcharts. Those are like a circle with the or a pyramid if you wanna define it. They have a pyramid like shape management. Okay, thank you everyone, and see you soon inshallah.